Hello, and thank you for attending Virtual SAGES 2020. It's a pleasure to be speaking here today. Thank you to SAGES and Danielle Walsh for inviting me to speak in this adolescent weight loss surgery, how to get them through college. My assigned talk is pediatric guidelines, which I happen to know a little bit about, and I'm going to discuss specifically the indications and patient selection. First of all, I have nothing to disclose. To give you an idea of where I'm going with this, I'm going to talk about the history of pediatric metabolic and bariatric surgery guidelines, concentrating on the ASMBS guidelines published in 2018, and the premise on which those guidelines were based, as well as the changes that those guidelines brought from 2012. Next, I'm going to discuss the AAP statement published in October of 2019 in pediatrics that Danielle may have already discussed a little bit. And then I'm going to give a summary of the indications and patient selection. So as many of you know, the NIH in 1991 held a consensus conference, and the first guidelines for bariatric surgery in adult patients came out then. And they made cutoffs of BMI of 40 or a BMI of 35 with comorbidities. And these have been adopted fairly universally today for the application of metabolic and bariatric surgery. They also recommended using a multidisciplinary team and long-term follow-up, both of which have also persisted as significantly important guidelines. The one thing they did say, though, is that they could not recommend for or against surgery in children and adolescents. So in 2004, Tom Inge and a group of interested pediatric and adult surgeons got together and put together concerns and recommendations for using bariatric surgery in severely overweight adolescents. And theirs looked at patient evaluation and selection, as well as surgical treatment and long-term follow-up. Around the same time, there was a group in Boston funded by the Betsy Lehman Center for Improved Public Health. And we were also working on a set of best practice guidelines. Carolina Povian was the chair of that committee. And in 2005, we published the best practice guidelines for pediatric adolescent weight loss surgery. And I was involved in that publication. And we looked at patient selection, specifically BMI cutoffs, comorbidities, maturity. We also looked at multidisciplinary management, informed consent, risks, and outcomes. In 2009, I chaired the committee that updated those guidelines, again funded by Betsy Lehman. And in that, we addressed the same as the initial guidelines, plus we talked about the team makeup, the evaluation, and operation choice. In 2012, Mark Mikulski called me up and said, hey, the ASMBS Pediatric Committee is putting together a set of guidelines, and we'd like to base it on the 2009 guidelines that you were involved with, as well as adding all of the newer pediatric data that's come out over the last 3 or 4 years. So I was happy to participate in that guideline as well. In 2018, soon after becoming the chair of the pediatric committee for the ASMBS, we published the pediatric metabolic and bariatric surgery guidelines. And the biggest change here was to use the terminology pediatric instead of adolescent, to try to get at the idea that we shouldn't be basing our decisions on age. Now, Dr. Armstrong and the Obesity Committee of the American Academy of Pediatrics in 2019 came out with a even more stronger emphasis on the fact that metabolic and bariatric surgery should be based on BMI alone, with some other things that I'll discuss as we go through. So what was the premise of the changes we made since 2012 when we published the 2018 guidelines? First of all, in 2013, obesity became recognized as a metabolic disease mediated by neurohormonal pathways that are predominantly genetic. And so finally, we were working with a treatment for a disease as opposed to a treatment for obesity, which many people felt was under volitional control through unconscious bias and prejudice, there was a lot of feeling that, you know, these kids should be able to lose weight on their own, or they should be taken out of their home and put with different parents, and then they'll lose weight. We also found that diet and exercise alone could not be considered adequate treatment for severe obesity, and we wanted to emphasize this in our guidelines. Finally, the MBSAQIP had started accrediting programs in adolescent and bariatric surgery, and their accreditation covered quality improvement, treatment teams, protocols, and facilities, and are really excellent. And we didn't want to step on any or have different guidelines than the MBSAQIP. So for those specific things, we deferred to the MBSAQIP, and even if a program wasn't going to be accredited, we recommended following their guidelines. And then finally, there's been a major shift in thinking about the treatment of severe obesity. The idea that of more of an oncologic approach, so instead of using surgery or medications, that really we need to use surgery and medications and lifestyle changes, exercise, eating changes. All of these things need to be incorporated in order to have a successful outcome for a patient who comes in with very severe obesity. Finally, we used in the 2018 guidelines the definition of adolescence by the World Health Organization, which is 10 to 19. And the reason we finally put an age in there before we had never had an age was simply because before, without an age, the insurance companies and other entities were deciding on random ages like 14, 16, and other factors that really have nothing to do with outcome. And so we felt it was important to at least say that. And when we said that, we also had a caveat that a younger age might be appropriate in certain situations. So what do we use as BMI cutoffs? Another major change, and you'll see all the changes that we made are in red. So we used to use a BMI cutoff of 40 and 35, and we felt that was very conservative because as you go younger in the growth chart, the BMI cutoff actually should decrease. It should follow the growth chart. The pediatric definition of class 3 obesity is greater than 140% of the 95th percentile. That's the pediatric definition. At 18, in most genders, that's about a BMI greater than 40. The pediatric definition of class 2 obesity is 120% of the 95th percentile. And so the cutoff is 120% of the 95th percentile with a comorbidity, and 140% of the 95th percentile. Either one of those would be good cutoffs to use in children. And the way this makes a difference is that this star here represents a BMI of 30, and it's a 10-year-old, and in a 10-year-old, a boy, a BMI of 30 is the same as 120% of the 95th percentile. So if you have a child who's 10 years old who has a BMI of 30 and a comorbidity, that child should qualify for metabolic and bariatric surgery based on the new guidelines. Whereas before, we would have to wait until that child had a BMI of 35 or 40 before we could operate. We also changed the comorbidities that we considered significant. So before, there was a limit on the sleep apnea, and we said any sleep apnea is not good. We continued with type 2 diabetes, of course, and insulin resistance. NASH, or non-alcoholic steatohepatitis, again, any NASH is not good. Intracranial hypertension, orthopedic complications like Skiffy and Blount's, which are clearly associated with obesity, could be improved by bariatric surgery. Cardiovascular risks have been shown in more recent studies to be significant in children with obesity. Hypertension, hyperlipidemia, insulin resistance, and elevated CRP all contribute to increased cardiac mortality in the 30s and 40s for adolescents who are obese. Health-related quality of life significantly affects children who have obesity, and we felt that it was important to add that as one of the possible comorbidities. And finally, gastroesophageal reflux disease. The contraindications, mostly we removed contraindications. There really shouldn't be a lot of contraindications. The ones that we removed were depression. As long as it's treated and stable, there's no contraindication. Eating disorders, again, treated and stable, there's no contraindication. A history of trauma, these patients probably need more support surrounding surgery, but there's no contraindication to surgery. Unstable family situations have never been shown to lead to decreased outcomes or poor outcomes after surgery. And there's no reason, because a family's in an unstable situation, to necessarily postpone surgery if that's not going to change over time. Autism spectrum, syndromic obesity, and developmental delay are all now not contraindications to surgery. Each patient is individual, and obviously there may be some who won't be able to follow guidelines or to fit in, be able to tolerate surgery, but those that can, there is no contraindication. And then finally, children who are unable to assent to surgery. This should not be a contraindication. We do tonsillectomies on patients who have sleep apnea, and we never think twice about it, whether the kid has to understand what a tonsillectomy is before we do it. And there's no reason that a treatment for obesity should be any different. Barriers to surgery were removed as well from the guidelines. There were many guidelines that suggested a preoperative diet was necessary. There is no evidence to support any different outcomes in patients who've tried dieting before or haven't tried dieting before. Tanner stage, there's no data to suggest that development, that normal hormonal development is changed by or delayed by bariatric surgery. In fact, it may be more normal after you treat the obesity. Bone age, there is zero evidence of decreased linear growth, and there's only one study out there which shows improved linear growth with bariatric surgery in children who suffer from obesity. Finally, again, we stated the guidelines of an age 10 to 19, considered routine, with younger okay in special circumstances. We also suggested that obesity is a disease, and specifically mentioned that in the guidelines. We also emphasized that delaying surgery only leads to higher BMIs and more comorbidities. The American Academy of Pediatrics came out with a policy statement which took it one step further. This was published in October of 2019, and they stated current longitudinal studies evaluating safety and efficacy endpoints do not apply specific age limits for the timing of surgery. Thus, there is no evidence to support the application of age-based eligibility limits. There should be no age-based eligibility limits. The AAP went on to use BMI, not age, as an indication for surgery, and their indications are simply weight criteria. A BMI class 2 obesity, or a BMI of 35 or 120% of the 95th percentile for age and sex, whichever is lower, and then clinically significant disease, including obstructive sleep apnea, type 2 diabetes, intracranial hypertension, NASH, Blount's, SCFE, GERD, and hypertension. You can see their guidelines are very similar to ours. And then finally, class 3 obesity, or a BMI greater than 40 or greater than 140% of the 95th percentile, whichever is lower. So any way you cut it, we need to be using BMI. And let me explain why this is important. If we use the percent of the 95th percentile, if you take this patient who I met when she was 15 years old, this patient, when she came in at 15, had a BMI of 50. If I had met her when she was 10 years old, her BMI was 32, 18 points lower. At this stage, I will be lucky to get her down to a BMI of 32 with bariatric surgery. If she had bariatric surgery when she was 10 years old, she could have easily gotten down to a normal weight, a normal BMI. And if we can achieve a normal BMI in children, they have a chance at a normal life with lower risk of early mortality from all the comorbidities associated with obesity. The AAP policy also went on to talk about the contraindications, and there are very few contraindications. A medically correctable cause of obesity, obviously, if someone has severe Cushing's, or if they have any issues with their thyroid, those need to be treated first. An ongoing substance abuse problem, obviously we want that stable and treated. medical, psychiatric, or psychosocial or cognitive problems that prevent them from adhering to the postoperative dietary and medication regimens. This can actually be tested before surgery, and I'll talk about that in the next slide. And then current or planned pregnancy in 12 to 18 months. It's important to counsel kids about not getting pregnant and to help them with birth control as part of the surgical planning. Indications and patient selection. Class 2 or Class 3 obesity, Class 3 or Class 2 obesity with a comorbidity. Patients do not have a medically reversible cause, and you can have them cleared by a pediatric obesity specialist to show this. Patients are psychologically stable. You can have them cleared by your psychologist through an evaluation to clear this. And then patients can demonstrate an ability to comply to the program. So we want to see either evidence of weight stability or decrease when possible. Some children with genetic obesity, I've found no matter what we do, we cannot get their weight to slow down. They're still putting on weight. Evidence of an ability to follow a liquid diet for 2 to 3 days. So in a patient with severe autism or developmental delay, we'll ask the parent to put the child on a liquid diet for 2 to 3 days and see that they're capable of doing that. And if they're capable of doing that, then we look at other factors like hospitalization. If they're capable of tolerating hospitalization and IV fluids, then we can proceed with surgery. We also want to know that they're taking their vitamins regularly. Now, it's very easy to figure this out. All you do is you start them on vitamins when they start in your program. You check their vitamin levels. 3 to 6 months later, you check their vitamin levels again. You can tell if they're taking their vitamins, and if they are, you proceed with surgery. And then attending regular visits. Our visits last for 4 to 6 months, sometimes a year preoperatively, and the visits always involve a dietitian. And it's during this time that the children and the parents learn how to eat and make those lifestyle changes necessary to be successful after surgery. We also want the patient assent for the procedure if possible, or the parent consent to the procedure. And finally, we want the benefits to outweigh the risks. If the benefits might not outweigh the risks, then we'll usually bring in the ethics committee and ask them to weigh in on whether we should operate on a child. And an example of this would be someone with congenital heart disease where anesthesia is quite risky. And we might, sit down with the ethics committee and the anesthesiologist and figure out that maybe we can't offer this child an operation. So thank you for attending. These are my 4 sons and my granddaughter, and I hope to see you at the next in-person SAGES meeting. Thank you very much.